Hello, my name is Dr. Shasindran. I'm a clinical ONG specialist in Hospital Teluk Intan. Today we are here for the dengue update. I'd like to thank the medical department, especially to Dr. Brian and Dr. Eileen for giving me the opportunity to give my talk regarding dengue in pregnancy and what we expect when we come across a patient with dengue in relation to pregnancy. So without further ado, this is going to be all my keynotes. Shall be talking and touching about a few important points and aspects pertaining to pregnancy as well as dengue. So as an introduction, we knew that dengue is a systemic infection that causes by the dengue virus. It's a major public health problem over 100 endemic countries. The infection has nearly caused around 58.4 million annual symptomatic cases and over 10,000 deaths per year globally. So when it comes to pregnancy per se, pregnant mothers who are living in this endemic area can be at risk of developing the disease. So as we know, as we have been seen in the slides prior to Dr. Eileen, we know that it is being transmitted by the Aedes aegypti and Aedes albopictus. So there are 4 different types of. So when it comes to pregnancy, most of us believe that dengue per se is similar to adult disease, but there are a couple of changes that occurs during pregnancy. And these changes may facilitate to a different clinical presentation and scenario when we look at patients having dengue in pregnancy. So I'm going to touch the physiological changes and the relation. So let's start off with the cardiovascular system. So when a patient is pregnant, her pulse rate usually goes up and peaks at around the 3rd trimester. Typically a resting pulse rate would be around 90 beats per minute. Any heart rate more than 100 without fever warrants for further investigation. When it comes to blood pressure and systemic vascular resistance, diastolic blood pressure and mean arterial pressure decreases more than systolic blood pressure during pregnancy. This is reflected on the increase in pulse pressure. Raise in arterial pulse pressure will return to preconception states, usually postpartum. The degree of change in BP is acutely influenced by maternal position. One thing we do see is that whenever we take a blood pressure monitoring for our pregnant mothers, we tend to give them a tilt of 15 to 30 degree lateral tilt. This is why, so that it can help with giving the adequate and correct blood pressure, because physiologically in supine position the venous return to the heart is actually reduced by 30 to 40% due to the compression of the inferior vena cava by the gravid uterus. So there will be a reduction in cardiac output and hence the blood pressure. So when it comes pertaining to dengue, a change in blood pressure will lead to a wider pulse pressure in pregnancy. Pulse pressure dropping from 30 millimeters of mercury to 25 is strongly suggestive of patient heading towards compensatory shock that requires immediate attention and resuscitation. Always remember, when we are taking blood pressure for pregnant mothers, always have a 15 to 30 degree lateral tilt. This is crucial to minimize over resuscitation with fluid as well as getting the correct blood pressure. When we look at pulmonary vascular resistance, there is a reduction in pulmonary vascular resistance in pregnancy. So this in turn causes due to the increase in pulmonary blood flow with the normal mean pulmonary artery pressure. So serum colloid osmotic pressure is reduced by 10 to 20% due to the reduction in albumin levels. So when this occurs, this is what gives the susceptibility of pregnant mothers to develop APO, acute pulmonary edema, when they are overfilled with fluid. So one of the things in dengue, there is the level of capillary leakage is intense, and hence this increases the susceptibility of pulmonary edema. Secondly, plasma volume and blood. Plasma volume actually expands progressively until the third trimester. We are looking at around 30 to 50% of increment of it. So when we are looking at that in comparison to normal pregnant, compression and involution of the uterus may lead to the volume returning back to the systemic circulation. So blood transfusion is basically not required after a normal blood loss postpartum, but due to physiological changes, hypotension might be much more later compared to non-pregnant women, and patient should be evaluated accordingly if a transfusion is needed. In cases of hemorrhagic fever, a transfusion is. Let's talk about the hematological changes and biochemical changes. So we notice that in pregnancy, many of the time we come across patients having anemia in pregnancy, maybe due to IDA. So what causes this physiological or hemodilution in pregnancy whenever we see in our full blood picture results? The red cell mass actually increases steadily. I remember talking to you all about the plasma volume increasing around 30 to 40%. With the increment of the red cell mass, this leads to physiological anemias, where you would see reflected on your full blood picture showing hemodilutional in pregnancy. Hematocrit will revolve around 32 to 34%. However, in case of dengue fever and dengue hemorrhagic fever, raising hematocrit of more than 20%, let's say around 38 to 40, might show that there is a significant capillary leakage. White cell count. In pregnancy is associated with leukocytosis. During pregnancy, the white cell count can reach up to 15,000 and can be as high as 25,000 postpartum without any fever or clinical suspicion of sepsis. This is the cell-mediated immunity is suppressed in pregnancy to prevent the rejection of fetus. So this is what that makes pregnant mothers very susceptible to infection. As you can see, we are always treating mothers for asymptomatic bacteriuria by sending an MSU-CNS for their urine because of this cause of susceptibility to infection. So the same way, in case of dengue, when you see a white cell count of less than 5,000, which is your leukopenia, it may not be seen as such in the febrile state, but a downward trend of WBC is important even in the absence of leukopenia, and this may be suggestive that patient might be suffering from the. Next, this is the most commonest biochemical result that we see in dengue fever. In pertaining to pregnancy, a mild drop in platelet is always seen in the pre-pregnant level and is common in all women in uncomplicated pregnancy. When we talk about the diagnosis of gestational thrombocytopenia, it usually occurs in the second or third trimester, but one should remember that the platelet seldom drops to less than 75 in gestational thrombocytopenia. If it occurs in the first trimester, usually it is caused by an immunological response, and that needs to be investigated. All patients with platelet that is less than 100 needs to be investigated. I hope you bring this back to your practice. So, in reference to dengue illness needs to be excluded when your platelet is low. However, there are other differential diagnoses like preeclampsia and also HELP syndrome, which is a complication of preeclampsia where you have your hemolysis, elevated liver enzymes and low platelet. The decision for transfusion depends on the mode of delivery. For us, vaginal delivery, a platelet count of more than 50 would suffice, and for LSAS, a count of more than 80 and above is what is required. Platelets should be readily available during delivery, or if of any surgical intervention. If the bleeding is excessive, we would need to transfuse the. As far as coagulation profile and coagulation is concerned, pregnancy is a prothrombotic state because there's increase in coagulation factor, platelet activity, and also reduce in fibrolysis. This is usually seen in your coagulation profile whereby the PT and APTT is slightly reduced with an INR of less than 1. When you have a reduced platelet, you have increased bleeding tendency and also inability to clot. So dengue hemorrhagic fever causes the bleeding to be even more excessive. When we look at serum albumin, the levels of serum albumin is low in pregnancy, around 25 to 28. So when there is plasma leakage occurring in dengue hemorrhagic fever, albumin also leaks into these potential spaces only to return with reabsorption. So in pregnancy, patients tend to get edematous, so there is a lot of third space fluid loss. Indirectly, with the feature of this, the patient might be losing even more fluids and causing them to go into hypotensive shock. When it comes to the respiratory system, basically a pre-pregnant woman has abdominothoracic breathing, but in pregnancy there's only thoracic breathing because of the growing of the gravid uterus. So pregnancy per se will have a physiological respiratory alkalosis with an increase of PO2 and a reduced PCO2 in view of the growing uterus. So these are the few respiratory changes that occurs where your functional respiratory volume is reduced, causing this less oxygen reserve, increased ventilation and respiratory drive. There's an increase in tidal volume with normal respiratory rate. There's respiratory alkalosis where your PCO2 drops to a level of 27 to 32. Higher mean arterial O2 tension ranging of 106 to 108. So in this, a PaO2 of more than 70 millimeters of mercury and SpO2 of more than 95% is required for adequate fetal oxygen delivery. So when you come across a patient with hemorrhagic fever, like I said just now, they can have capillary leakage causing them to have pulmonary edema. If we see a respiratory rate more than 25, this is alarming and patient may need attention. In a non-pregnant complicated dengue patient, a pH of less than 7.35 together with a bicarb level of less than 15, early correction is recommended to prevent bleeding and DIC. But in pregnancy, the threshold for correction of an acidosis should be early. If acidosis persists after fluid resuscitation, further intervention would be needed. Arterial oxygen tension and SpO2 are low due to ventilation perfusion mismatch as a result of pleural effusion. So patient may require oxygen, positive and expiratory pressure and mechanical ventilatory support in order to maintain the saturation of more than 95% and also the tension of more than 70 millimeters of. As far as the renal system is concerned, glomerular filtration rate is increased from 50 to 85%, and this is increases, and this increment occurs causing the patients of pregnancy or who are pregnant to have frequent urination, but rarely more than 3 liters per day. In dengue hemorrhagic fever or shock, intense thirst may not appear despite intravascular volume depletion, and a normal urine output may persist. Therefore, urine output may not be a good marker to indicate the degree of shock. So yeah, we will place a CVD in situ. However, if the patient is oliguric, basically she needs even more fluid. So as far as the clinical presentation is concerned, this is similar to any clinical presentation of a normal adult dengue hemorrhagic fever. So the incubation period is usually around 4 to 7 days. The range can go from day 3 to day 14. Patient may be asymptomatic and may result in a spectrum of illness ranging from undifferential mild febrile illness to the severe disease with or without plasma leakage and organ impairment. Symptomatic dengue infection is a systemic and dynamic disease with clinical, hematological and serological profile change from day to day. Thereby what they are trying to say is we have to monitor the patient depending on which stage she is in, and depending on what phase she is in, we shall give the required and resuscitation. So when we look at the clinical course in dengue, they start off with what we call as the febrile phase. Patient develops high-grade fever suddenly. This is usually associated with facial flushing, skin erythema, generalized body ache, myalgia, arthralgia and headache. Some patient may have sore throat, injected pharynx and conjunctival redness. Anorexia, nausea and vomiting are also common in this phase. When it comes to the critical phase, occurs towards the late febrile phase, usually after the 3rd day of fever and around the defervescent phase, where it's usually at the 3rd or the 5th thing, where there will be a rapid drop in temperature which may coincide with increased capillary permeability in the patient. At this point, the patient will either become better if no or minimal plasma leakage occur, or critical if the plasma volume is lost. I'm very sorry for the slides. I think during my presentation it has run off. I hope you. As far as the recovery phase is concerned, after 24 to 48 hours of defervescence, plasma leakage will stop and it's followed by reabsorption of the extravascular fluid. Patient generally will be well, appetite will return, gastrointestinal symptoms will disappear, and patient will be hemodynamically stable, and the diuresis will occur. Some patient may have a classical rash of aisles of white and red and a sea of red. Some may experience generalized pruritus. It is important to note that during this phase your hematocrit levels will stabilize and drop further due to the hemodilution following the reabsorption of the extravascular fluid. Recovery of platelet count is typically preceded by a recovery of white cell count. With this. So as you can see from this slide, you can see the differences of a normal circulation, compensated shock and decompensated shock, where the patient is more hypotensive. So depending on how the patient present, this is how normally the patient will present to us in a normal circulation. When she's in compensated shock, you will see that the weak and what you call more colder extremities, weak and thready pulses, she's tachycardic, but you can see that her blood pressure is still somewhat maintained, but she would have some amount of postural hypotension, narrowing of pulse pressure. Patient will be tachypneic. There may be a reduced urine output, or as far as I'm concerned, normal urine output. But when it comes to decompensated shock, patient will be more restless, lethargic, skin will be molted skin, she's more cold and clammy, the pulses will be more feeble, tachycardia might progress to bradycardia in later shock, hypotension with unrecordable BP, a narrow pulse pressure of less than 20 millimeters of mercury. From the respiratory alkalosis, patient might develop metabolic acidosis, hypernemia, small bleeding, and she might go to even becoming anuric. So this is another slide. All this is taken by our continuous CPG guidelines of dengue in pregnancy, which was brought out by our Ministry of Health. So as you can see, this is how the presentation would look like. And as you can see how initial part the temperature is raised, followed by where the temperature is subnormal. You can see the patient will be dehydrated in the febrile phase, and she might go into shock and bleeding when impairment is occurring. Hematocrit will be raising in the critical phase while the platelet is dropping, and then finally going back up again in the recovery. So the viremia stage would be in the initial first 3 days. That's when you can start seeing the IgM and IgG in your blood test. So this is also a very important slide, because most of the time when we look at patients coming up with some sort of disease, we fail to have a differential diagnosis for them. So when a patient comes pregnant or non-pregnant with a flu-like syndrome, we have to rule out influenza, measles, chikungunya, adenovirus, infectious mononucleosis, and acute HIV seroconversion illness. Alright, depending on what is familiar to your unit and your tropical disease, that would be what is most commonly you will see in your center. So if your center is more common for dengue, you will see dengue. You're not going to see chikungunya at that place. As far as rash is concerned, because the patient is pregnant, it can also mimic like a rubella disease, measles, scarlet fever, meningococcal infection, chikungunya, and it may be drug caused. Now diseases, diarrhea also can be from rotavirus or food poisoning. Neurological manifestation like meningoencephalitis or febrile seizures can also present in a similar fashion, a similar way. I came across during my practice when I was working in Kesihatan once for a patient who came to us with a simple complaint of just diarrhea. A mild fever with diarrhea. And when we did an NSR for her, it was positive for dengue. So sometimes the presentation is very, very different and unique, and the patient might not come to you with a similar pattern and similar way of what the classical books have taught you. But if you have a high suspicion that the patient is contracted the dengue illness, please. So in cases of dengue shock in pregnancy, a compensated shock is mainly this. I think I've showed you in the slides prior to this on how a patient would get shock and decompensated shock. So this is just a repetition and what you call recap of what we have just seen now. Let's talk about other manifestations. So like I was saying, some patients might come to you with acute abdomen, and acute abdominal pain may be a common symptom in dengue infection, maybe due to hepatitis, acalcular cholestasis with shock, or and it's occasionally misdiagnosed as acute abdomen. So remember, history taking is vital and important, in which we have to elicit the onset of fever followed by laboratory findings like leukopenia, thrombocytopenia, and prolonged PT and APTT. This may help give a good differential diagnosis whether or not this dengue infection or any other surgical cause. Hepatitis and liver failure hepatitis is very common with dengue and dengue hemorrhagic fever, because the patient might have a mild version or a severe version of the disease secondary due to the plasma leakage. In some cases, patient may develop liver failure. So when they are in failure, there's a high potential of the patient to bleed, especially from the gastrointestinal tract. Neurological manifestation is actually rare. It's less common. It's less than 1%, where the patient might develop encephalitis or encephalopathy. Rare manifestations like myelitis and Guillain-Barré can be seen also. For the Hematophagetic Syndrome, this is a very uncommon syndrome where there's a overactive cytokine production resulting in activation of T cell and macrophage system following a dengue virus. There will be a cytokine storm where the patient may develop severe vascular injury followed by immense plasma leakage leading to cellular edema, damage, necrosis and cell death. So this is also a very rare manifestation. So when it comes to dengue illness, again they can come to you in acute abdomen, shock, respiratory distress and leukopenia and things. Do not forget to have a differential diagnosis. You might always think that this is dengue disease, but there might be another surgical, medical or what you call autoimmune disease that may be lurking around. So these are also the differential diagnosis for dengue illness during critical phase. So admission criteria, as far as we are all concerned, all pregnant women with acute onset of fever should be advised to get admitted early to the hospital where a specialist cover is available with the FBC. First contact doctor should make a comprehensive assessment of the patient in order to decide whether or not the resuscitation will be in the A&E or the obstetric / medical unit, or irrespective of the duration of fever. Let me just tell you that in comparison to a non-pregnant patient, a pregnant mother will always compensate. So they always come to you in two extremes. Either they are well or they are in shock. So our evaluation is very important. Let's not forget that involving the public, the field staff and also the family health officer is also important, and also the public health inspector, in order to sit and cordon the place where this disease has occurred, and notification is also equally important. Admission letter is also important. So this was a beautiful diagram I took from the dengue CPG guideline, the Sri Lankan CPG guideline for dengue, whereby they have given off the in a clinical state where the patient should be what you call monitored. So when you're talking about dengue fever that is uncomplicated but with a complicated pregnancy, most of the time it would be what you call admitted in the obstetric ward, because complicated pregnancy sometimes may warrant for further evaluation and observation. But when you are looking at dengue hemorrhagic fever in an uncomplicated pregnancy, most of the time the admission would be either in a medical ward or in a high dependency unit. In case of dengue shock, you would need an ICU, and if you are in a secondary care, she would need to be sent to a tertiary care unit. As far as the blood investigation is concerned, I think Dr. Eileen has spoken to us and informed us on what are the important blood investigations that is needed and how to confirm the diagnosis. So I'm not going to touch so much about that, but these are the blood investigations that is very vital and crucial when it comes to patients in pregnancy. So when we look at the white cell count, most of the time the white cell count will be normal, but there will be some amount of may decrease rapidly as the disease progresses. The trend of leukopenia should raise the suspicion of possible dengue infection. Secondly, for the hematocrit, as I spoke to you about the plasma leak, the hematocrit may increase tremendously, which may need further fluid resuscitation for the patient, and the reabsorption will cause the hematocrit to come back to normal. As far as the thrombocytopenia is concerned, in febrile phase, platelet is usually within normal range, and it will decrease rapidly as the disease progresses to a late febrile phase or at defervescence, and it may continue to remain low for the first few days of recovery. So that is for the platelet count, as long as the patient having any bleeding tendency. The other thing we have to look at, as what I mentioned in my previous slide, that there would be elevated liver enzymes, especially the AST in comparison to ALT, because of the changes and plasma leakage that is occurring, and it's more higher with dengue hemorrhagic fever in comparison to dengue fever. So this is the take-home message what you see in yellow. Leukopenia followed by progressive thrombocytopenia is suggestive of dengue infection. Raising hematocrit accompanied with progressive thrombocytopenia is suggestive of dengue hemorrhagic fever. We do not know what is the baseline, but this is roughly the baseline of what they've given for the hematocrit. As far as our concern is, it is important to keep repeating the blood investigation daily in order to sit and see the progression. So, as far as the history taking is concerned, stepwise, it is very important to take good history. So, these are the important aspect of the history that has to be dealt. Onset of fever, the oral intake, diarrhea, bleeding, your mental state, the urine output, family or neighborhood history of dengue, jungle trekking, swimming in a waterfall, recent travel, or recent unprotected sexual or drug use behavior. Because even though we are talking about dengue per se, no, you can't transmit dengue from one person to another, but you might consider HIV seroconversion illnesses to mimic similar to a dengue disease. And also let's talk about other comorbids such as diabetes mellitus, and in case whether the patient is in sepsis. Physical examination, like how we do, we look at the skin color, cold, capillary refilling time, pulse rate, pulse volume, blood pressure, pulse pressure, whether or not the respiratory rate, any abdominal pain or tenderness, hepatosplenomegaly, ascites, examine the bleeding manifestation, a tourniquet test, a simple tourniquet test. Investigation would be your FBC, a simple FBC will give you suffice. Liver function test to see whether or not the patient is having any liver involvement, and serology. So once the diagnosis is done, what is the phase is what we should sit and think, whether she's in a febrile, critical or recovery phase. Hydration and hemodynamic of the patient should be seen, whether is the patient in shock ethic and whether the patient requires admission. So this part is more commonly seen in adult disease, but as far as dengue is concerned, all dengue cases in pregnancy should be admitted and observed. So as long as they come down to their recovery phase, then they are free to be sent home. The warning signs are also equally important. The patient is having abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation, effusion and ascites, mucosal bleeds, restless and lethargy, tender enlarged liver, or even increased hematocrit with concurrent rapid decrease in platelet. These are all warning signs, and the treatment modality is important and should be given. Disease monitoring per se, if the patient is febrile, differentiation of dengue illness from other febrile illness, because some patients with viral fever may have a reduced platelet count, which in turn will improve then after. So taking a dengue serology at that time will sit and tell you whether or not this is dengue or not. In case of the critical phase where plasma leakage has occurred progressively and the patient's temperature is becoming lower, the deterioration may be due to plasma leakage. And remember, plasma leakage will cause hemoconcentration followed by hypovolemia or shock. So how do we manage this? Intravenous fluid, as what Dr. Eileen would have spoken to us in her slide. So the fluid that is given will help resuscitate the patient, but overloading her with fluid may cause respiratory distress. The bleeding per se may cause the patient to go into prolonged shock, and shock also can be perpetuated by the bleeding, and the other things follow. As when we come to the reabsorption phase, there will be a stop in plasma leakage, reabsorption will occur, the hemoconstitution will in turn become hemodilution, the hypovolemia and pulmonary edema will be treated accordingly with medication, but the fluid therapy should be continued in a fashioned way. So depending on how the patient presents to us, whether in the febrile phase, critical phase or recovery phase, this would be how we would want to monitor the patient on her urine, on how her general well-being is, whether you like to see her twice or thrice a day depending on clinical symptoms, hemodynamically, how often we like to take the blood pressure and all the vital signs for her, and in recovery phase it's usually similar. If the patient has signs of bleeding, tenderness and ascites, how often we would like to sit and observe and monitor her, and as you can see, the urine output is also equally important, monitor. As far as the FBC is concerned, we will do it daily in the febrile phase, but when it comes to critical phase, she might need around 4 to 12 hourly FBC, because depending on what fluid resuscitation we are giving in accordance to Dr. Eileen's slide just now, every time we give her bolus doses of fluid and everything, we would need to sit and see whether or not there is some amount of recovery seen in her FBC and hematocrit. So in recovery phase, daily monitoring would suffice. As far as all the other blood investigation, it depends on how the patient's clinical presentation is. But if the patient is in ICU, most of the time all these results will be repeated as daily or frequently as in. So I'm now going to touch on the fluid resuscitation, because this is similar to what Dr. Eileen has spoke. So, but I would like to sit and talk regarding the challenges that what we come across, especially in pregnant mothers. So a multidisciplinary team approach is needed. The first and foremost thing is when patient is let's say at term and she comes to you with dengue hemorrhagic fever, avoiding induction of labor or elective cesarean section during this critical phase of illness, it should be avoided. It's best to delay till the patient reaches recovery phase. If delivery is inevitable, delay it until the platelet count resumes to recover, or to increase your platelet count of more than 50. So occasionally therapeutic platelet transfusion may be needed before an intervention. So if we are going to do a cesarean section for thing, we would like to bring her platelet to more than 80. If premature labor occurs during critical phase, it's advised to delay by using tocolytics. So what we use is nifedipine and atosiban. With nifedipine, in a normotensive patient, nifedipine does not reduce the blood pressure significantly. However, we should avoid it in cardiac disease and hypotension if your BP is less than 90 by 50. And we have to be also cautioned if the patient is tachycardic from the nifedipine. Due to the vasodilatation induced by nifedipine, maternal monitoring should be monitored even during the critical phase of vaginal delivery or cesarean section should be undertaken only if mother's life is at risk. Remember, mother comes first, not the baby, and or the patient develops spontaneous labor during this period. If there is a fetal distress for delivery, it is recommended not to intervene and deliver during critical phase. Remember again, mother comes first. Patient and relative must be counseled about the risk to the pregnant woman's life if intervene at this time, either by induction or cesarean section. Decision should be taken by a multidisciplinary team, and indication and reason for non-intervention should be well documented. Pregnant women should be monitored closely for vital signs and bleeding, while close continuous fetal monitoring is required to detect fetal compromise. Blood grouping and cross-matching as followed. Normal or instrumental delivery can be conducted under close supervision of the obstetrician. Majority of the patient can be allowed to progress to spontaneous vaginal delivery in recovery phase. There shouldn't be no problem with that. If elective delivery is best avoided in the diagnosis of dengue patient until patient's platelet has recovered for more than 50. Intense active management of third stage is important. So what we use is utrotronic drug. As far as the national guideline is concerned, what they suggest for is to give a 5 IV oxytocin as a slow bolus. We are not going to give IM for this patient because of bleeding tendency which can be brought about by the dengue illness per se. This should be followed by a oxytocin 40 international unit in a concentrated infusion under the standard protocol in order to avoid the patient going into fluid overload. Try to avoid ergometrin, as this can cause vasoconstriction and worsen the visceral ischemia in cases of hypotension in dengue hemorrhagic fever. In normal vaginal delivery or LSS, it is advised to replace the estimated blood volume loss concomitantly. In such patient, it is important to monitor the vital parameter and hematocrit frequently until the patient is stable. So it doesn't mean that the patient has lost a lot of blood. It's only if the patient has lost a lot of blood we'll need to replace the blood that is required. So transfusion will be depending on clinic. So this is another thing that we come across, whereby the patient starts, a pregnant mother comes to us with dengue hemorrhagic fever where she's bleeding. So bleeding is considered significant when it results in hemodynamic instability. Bleeding from the gums, vagina, epistaxis, petechiae are common but usually cease spontaneously and are often not significant. Significant bleeding or DIVC usually occurs following prolonged acidosis and shock. So as what you can see, I've highlighted in my yellow table here, hematocrit are not high as expected for degree of shock. It's to be explained by the plasma leakage alone. So if you are suspecting some sort of occult bleeding, these are the things that what you need to see. So again, transfusion is accordance to what we observe and the clinical response if the patient has lost quite a lot of blood. Consider repeating the blood transfusion if further blood loss is there. Patient with mild bleeding such as from gums or vagina, epistaxis petechiae does not need any blood transfusion. Upper GI tract bleeding can be managed conservatively. There are studies have shown that proton pump inhibitors or performing endoscopy is not required. Various guidelines mention that bleeding tendency will improve after 48 to 72 hours in defervescent. There is no role in transfusion of fresh frozen plasma or platelet concentrate. It does not reduce or decrease the bleeding tendency in dengue hemorrhagic fever. That's what the studies have shown. Inappropriate transfusion has a risk of exacerbation of pulmonary edema and respiratory embarrassment. So if you come across a patient who's bleeding and you believe that she needs a blood transfusion, transfusing her may overload her, resulting in. Now we come to the final part, whereby we follow through this discharge criteria. Following should be taken into consideration before discharging a patient. She should be febrile for 48 hours. She should have an improved general condition, improved appetite, a stable hematocrit, rising platelet count, no dyspnea or respiratory distress from pleural effusion or ascites, resolved bleeding tendency, resolution or recovery of organ dysfunction. This would be when and the only time where we can send the patient home. It might be a little bit more easier when dealing with an adult male or female, but in pregnancy most of the time the patient might look at you that looks like she is actually well and has fully recovered, but like I said, pregnancy always brings the disease to two extremes. Either the patients are well or the patients are in compensating tremendously. So be very, very careful before you discharge pregnant mothers who have dengue fever. I hope my presentation was extensive and we all learned something from here. So, but if you like to get further details, these are the guidelines that I had seen. The clinical practice guideline for management of dengue infection in adults and also in pregnancy. In adults, I think is 2010. I think in adults is 2015 guideline, while in pregnancy is a 2010 guideline. The clinical practice guideline on management of dengue in adult. This I took from the Sri Lankan guideline, which is of 2019. It was pretty extensive and it was a very nice guideline to read, and most of my slides were from this guideline. I also took another guideline from Thailand, where they had spoken about things whereby so these are the guidelines which you can sit and may help you in giving the best treatment modality and management for dengue in pregnancy. I'd like to thank again the medical department for giving me this opportunity to talk during the thing. I hope the slides were extensive and may help you back in your unit and your clinical practice. Thank you very much and have a nice day.